Hello and welcome to another video lecture on Chapter 20, where we're talking about alterations of hormonal regulation. And in this video, we're really going to talk all about alterations of thyroid function. And we'll first really talk about the differences between primary and central or secondary disorders. So when we talk about the primary ones, it means we have a dysfunction or disease of our thyroid, and it's going to lead to an increase or decrease in our thyroid hormone. Now, just to revisit the path that we take in order to get our thyroid hormones produced and released, you may remember from our hypothalamus, we're going to have our thyrotropin releasing hormone that travels to the anterior pituitary gland, tells it to make the thyrotropin stimulating hormone, which then travels to the thyroid gland and tells it to make our thyroid hormones, which are T3 and T4. Remember that the numbers here are noted based on how many iodine molecules that they have. So once we create these thyroid hormones, there's a negative feedback loop that goes up, tells the anterior pituitary gland we no longer need, well, maybe no longer, but we need to decrease the amount of TSH because we've got enough hormones, thyroid hormones. And then we also send a signal up to the hypothalamus saying we need to lower the amount of thyrotropin releasing hormone so that we don't overproduce the thyroid hormones. So of course we can have alterations throughout this pathway that can then alter the amount of thyroid hormones that we end up with. And then we can also have it disturbed idiopathically, basically meaning that it arose kind of spontaneously, and that could be due to autoimmune mechanisms as well. And I'm going to direct you over here to this figure from your book in which genes and as well as environmental factors are going to play into this to trigger that autoimmune response. And so we can have more of a cellular autoimmunity in which we're going to have anti-thyroid autoantibodies that are going to essentially start to destroy the thyroid gland, and that can lead to essentially hypothyroidism, where we're not getting enough secretion of the thyroid hormones. Whereas another path is through antibody-mediated autoimmunity, and here we are getting a stimulation of the thyroid gland, and in that way it can lead to hyperthyroidism. And we're going to talk about these two conditions in the coming slides. Now, with our secondary or central thyroid disorder, that means we have a disorder either with the pituitary gland or somehow affecting the TSH production. And when we have a excessive stimulation of TSH, then of course going down our pathway here, we are going to have an elevation of our thyroid hormones. And vice versa is true too. If we have a decreased amount of TSH, then we're going to have decreased thyroid hormones. So now we'll start focusing on specific disorders, and we're going to start with thyrotoxicosis, which is kind of an umbrella term. It's really referring to any condition in which we have an increased level of those thyroid hormone levels. And this could be done in a few different ways, but essentially we are talking about hyperthyroidism. And the key here is that we're seeing the increase in the thyroid hormones from the thyroid gland. So we can classify this as being primary or central or secondary. Primary is going to be more common, and Graves' disease is the most common cause. And this is pictured over here on the right-hand side here. We're going to talk about Graves' disease more on the next slide, but essentially we get these antibodies that start attacking the receptors on the thyroid gland. We also have toxic multinodular goiter, in which we could see the nodulations here becoming larger. And then we have solitary toxic adenoma, which we could see pictured over here. And then another cause could be by taking thyroid medication, and this could be due to, trying to increase the thyroid hormones if somebody has hypothyroidism and they kind of go over the other edge. Now notice in these scenarios, we are going to have low TSH coming from the anterior pituitary gland, and all of these situations are going to cause a rise within the thyroid hormones. With the secondary hyperthyroidism, we will see the cause would be through a pituitary adenoma. This is more rare, and we have our normal or high TSH levels, our thyroid hormones are going to increase. Our clinical manifestations are increased metabolic rate, heat intolerance, meaning that people feel overheated when the temperature around them starts to just rise minimally, and then we've got tissue sensitivity as well. The treatment is going to be anti-thyroid drug therapy, radioactive iodine therapy, or surgery. So as I said, we'll go through the diseases here. So we've got Graves' disease up first, and as we said, it's an autoimmune disease. And here's how our normal functioning thyroid gland is working, right? We get TSH that was released from the pituitary gland, attaches to the receptor. It stimulates the thyroid gland to release the thyroid hormone, and we get that negative feedback loop. But here in Graves' disease, you could see that we've got these autoantibodies, which they have various names that's been used in literature. So we're going to stick with thyroid stimulating immunoglobulins, or TSIs. And they attach to the receptors, and that stimulates the gland to produce an overproduction of the thyroid hormones. Now, the causation of this is unknown. There seems to be some type of genetic factor interacting with environmental factors that triggers this. And remember that this is a type 2 hypersensitivity. Now, as the TSIs are stimulating the thyroid gland, it causes the cells in there to undergo hyperplasia. And that is how we are going to get a goiter to develop. Some other manifestations that we're going to see, and probably something you noticed right away, is this ophthalmopathy. And there's two different categories of this, and about 50% of people suffer from this, where we get changes within the orbital contents, where we start to see an enlargement of the ocular muscles, or and we start to get accumulation of connective tissue behind the orbits that can also cause inflammation and edema. And so it causes the eyes to kind of protrude out like this. And this is known as exophthalmos. And because there were changes within the extraocular muscles, there will also be muscle weakness that is going to lead to diplopia, or double vision. In regards to ophthalmopathy as well, if there's functional abnormalities, there could be hyperactivity of the sympathetic nervous system, and that could cause a lag of the globe of the eye on upward gaze, and of the upper lid on downward gaze. Now, for people that have really high levels of TSIs, they may also experience pretibial myxedema, which you could see pictured over here. And this is when we have swelling on the anterior portions of the legs here. And we also have that erythematous skin. And this is because the TSIs are stimulating the fibroblasts and the T cells, causing a lot of hyaluronic acid production within the dermis. This may also appear on the hands, and it can give the clubbing of the finger appearance. So here's a little schematic of all we spoke about. Some of the other clinical manifestations are having a tremor, increased cardiac output, weight loss, flushing, heat intolerance, amenorrhea, and hyperreflexia. But moving on to hyperthyroidism resulting from a nodular type of thyroid disease, we have toxic multinodular goiter, and this happens when there are several hyperfunctioning nodules, which then excessively produce the thyroid hormones and hyperplasia of the thyroid gland. So here we don't have a autoimmune stimulus. And if we only have one nodule that's hyperfunctioning, then it's called toxic adenoma. Now, within either of these two types, we are not going to see the ophthalmopathy nor the pretibial myxedema, but we do see an increased incidence of malignancy. Lastly, here on hyperthyroidism, we've got our thyrotoxic crisis, or also known as a thyroid storm, which is rare. This is when our thyroid hormone levels rise dramatically, and it can be fatal. Death could occur within 48 hours if it is not treated. And we tend to see this in patients who are undiagnosed or partially treated for their Graves' disease. and are subjected to some type of psychological stress such as being sick and having an infection, or having gone through surgery, or going through dialysis. And we could see systemic manifestations such as hyperthermia, tachycardia, atrial tachydysrhythmias, and so forth that can then lead to death. So treatment of this would be to block thyroid hormones synthesis as quickly as possible. One could use beta blockers, glucocorticoids, iodine, and supportive care until they recover. Shifting gears now into hypothyroidism, and this is the most common disorder of the thyroid function, and it's more common in women. So hypothyroidism is when we have a deficiency in the thyroid hormones produced by the thyroid gland. And just like we saw with the hyperthyroidism, we're going to separate it into primary and central or secondary types. So with our primary hypothyroidism, this is more common, and we have lost the thyroid function. And this could be due to an autoimmune thyroiditis, and this is also known as Hashimoto disease. We're going to talk about it more on the next slide. It could also be due to a loss of thyroid tissue, and this is more of a iatrogenic loss of the tissue. Maybe they had surgery or radioactive treatment for hyperthyroidism, and then tissue became destroyed and so forth. Medications as well, such as lithium, and endemic iodine deficiency. With central or secondary hypothyroidism, this is more rare, and we have a failure of the pituitary gland here to synthesize TSH, or we have a lack from the hypothalamus of TRH, and it's not stimulating the thyroid gland to secrete the thyroid hormones. So typically this is caused from pituitary tumors and the associated treatments of that. And then I have this chart down here that kind of gives you the different levels of TSH, and also you can imagine this is our thyroid hormones here. So within primary, we'll see TSH is elevated, but even though we're getting that stimulation of the thyroid gland, we are not able to produce the thyroid hormones. With secondary, TSH is normal or low, and then our thyroid hormones are also low. Now there's this category of subclinical hypothyroidism, and this is a mild thyroid failure, and it's when we have elevated TSH levels and our thyroid hormones are at a normal level. And within the hypothyroidism clinical manifestations, we would have the patient experience decreased metabolic rate, cold intolerance, meaning they feel cold even on a warm day, and they can have lethargy. And although we've talked about goiters in hyperthyroidism, it is possible to develop a goiter within hypothyroidism as well, because TSH production is high and it's stimulating that thyroid tissue and causing hyperplasia. Now, if that hypothyroidism is severe and long-standing, that can turn into myxedema, which you see pictured over here. And this is from an altered composition of the dermis and other tissues. It produces a non-pitting, boggy type of edema that we could see around the eyes, the hands, and the feet. And the tongue and larynx and pharyngeal mucous membranes are going to start to thicken. So that produces the tongue to kind of become thick and stick out. It's also going to make the speech slurred and cause hoarseness. The best method of treatment for hypothyroidism is going to be hormone replacement therapy with levothyroxine, which is essentially a thyroid hormone. Now let's get into the specific diseases. In Hashimoto disease, we know that it is going to be autoimmune, and this will lead to a gradual inflammatory destruction of the thyroid gland. We fill the thyroid gland with autoreactive T cells, those anti-thyroid antibodies, and natural killer cells that cause inflammation, glandular apoptosis, and overall tissue destruction. That causes the thyroid hormone levels to plummet, leading to hypothyroidism, and some of the clinical manifestations we've talked about, in addition to decreased cardiac output, weight gain, and decreased mental acuity. Now, there are infants that are born with hypothyroidism, and this is when the infant's thyroid tissue is absent altogether, or with hereditary defects in their thyroid hormone synthesis. And this is important because our thyroid hormone is absolutely necessary for fetal growth and for the development of their brain tissue. So they will, if left untreated, suffer from developmental and cognitive disabilities. But as long as they receive treatment before 3 or 4 months old with levothyroxine that we talked about earlier, they are most likely going to grow normally and be able to function intellectually. The earlier the treatment takes place, the better. Next up, we have subacute thyroiditis. This is also known as decurvain thyroiditis, and this is rare, but it is a non-bacterial inflammation of the thyroid gland. And what's interesting is that it can develop after having a viral infection, and we typically see this taking place more with respiratory viruses such as influenza or the COVID virus, and it develops about 2 to 8 weeks after that viral infection. Lastly, we have postpartum thyroiditis, and this develops up to 6 months after giving birth and is, of course, similar to the subacute thyroiditis. The last topic to cover regarding the thyroid gland is thyroid carcinoma, and this is the most common endocrine malignancy. It's actually the 6th most common cancer in US for women. And one of the first ways people discover that they have thyroid cancer is by finding a small thyroid nodule or metastatic tumor in the lungs, brain, or the bone. And most people with this carcinoma have normal T3 and T4 levels, but will experience some clinical manifestive changes, such as a change in their voice or swallowing, having maybe some difficulty breathing, because as the tumor grows, it starts to impinge on the trachea, which is right behind the gland here, and it can also affect the esophagus, which lies posterior to the trachea. Ionizing radiation is the most common cause, and the most common way to treat this is through thyroidectomy, whether it's partial or total, and suppression therapy, such as levothyroxine, radiation, which most likely is used post-operatively, and chemotherapy.